One of the things that we're going to cover today, minimally invasive options and treatments for men who suffer with an enlarged prostate.
What I believe is like the coolest specialty in medicine right now. We've got outcomes that exceed what surgery can do, but we're doing it without the need for anesthesia. Most of our procedures are done with sedation and sedation only.
Why do you think most men don't know about PAE?
The whole goal is to increase patient awareness so they know there's other treatment options out there. The recovery is very tolerable. The complications are very low.
Let's just talk about the elephant in the room, sexual dysfunction.
Yeah, it's not associated with any of these negative side effects. In the near future, that the PAE will probably be kind of like first line treatment. We're providing like the best technologies and the best techniques. The goal is to improve their life.
Hi everybody, this is Rachel B. Singer here with the OBL and ASC Marketing Blueprint, brought to you by Patient Pro Marketing. Today I have a special guest from Georgia with me, Dr. Kevin Lee. Thanks for being here.
Hey, how are you? Thank you. Thanks for having me.
I'm good, great. Yeah, so one of the things that we're going to cover today are minimally invasive options and treatments for men who suffer with an enlarged prostate, or BPA. And so Dr. Lee, I'm excited to have you here because I know you have a lot of experience with some of these procedures that are out there. Tell us a little bit about your background and how you got involved with treating enlarged prostates to begin with.
So I think how we get, our specialty is vascular interventional radiology, and we are proceduralists with an imaging background. And, our specialty is kind of the integration, minimally invasive procedures, and while using the most advanced imaging modalities that are available, in today's scientific world. Kind of how I got started in this is, this is probably like what I believe is like the coolest specialty in medicine right now. We get to take care of patients. We have really good procedural options that are, minimally invasive. And what minimally invasive means is that it's a procedure, and we're not making incisions. We're not using cautery. Everything kind of gets done through a percutaneous access. And a lot of things that we do are endovascular, meaning that we're going through the blood vessels and we're treating certain conditions. The best thing about these interventional procedures is the fact that we've got, we've got surgical outcomes, or even outcomes that exceed what surgery can do, but we're doing it without the need for anesthesia. And most of our procedures are done with sedation and sedation only. And there's physical recovery is very tolerable, and it's done as an outpatient. Patients leave on the same day. So anyway, I think this is kind of a long roundabout way to get to figure out how I got into this. I'm kind of a technology geek, and I love computers and software, and my interest in vascular interventional radiology comes from a technology background and technology interest. During my training, I found a love for doing these procedures and started off doing a lot of advanced cancer treatments in the hospital by using these very similar techniques. We have the ability to do all these most advanced treatments, endovascular treatments, in the outpatient world.
Yeah, and prostates is just one thing, right, when it comes to embolizations. I mean, what we're talking about today in the IR space, the interventional radiology space, or endovascular space, I feel like embolizations have really blown up in the last few years in the States.
I think the awareness is out there, and the applications have broadened and expanded. There's a lot of commonality with like what I do, right? But it all really comes down to like, it's a procedure, it's interventional. We're going through the blood vessel system. It's all kind of the same thing, but just different areas.
Can you explain to everyone out there that doesn't know what an embolization is, what is prostate artery embolization?
The main thing is we're treating an enlarged prostate gland, which is called benign prostatic hyperplasia. If you've got the urinary bladder, and that's, what, holds the urine, okay, and you got the urethra that comes out, that's a little tube that goes to the penis, and then the urine kind of stored in the bladder, and then it goes to the urethra and, gets peed out into the real world. What it is, the prostate gland kind of sits underneath the urinary bladder. And then as the urethra comes out, if the prostate gland is big or grows, that it starts kind of constricting the urethra as it comes out, and it becomes kind of like like an obstructive, outflow issue. Though not life-threatening, it leads to lower urinary tract symptoms. And so What the embolization procedure is about is it's about what we do is we go through the male's, circulation, and we go to the prostate and we starve it of blood supply. And when we starve, an organ of blood supply, what it does is it causes that gland or that organ to atrophy and also soften up. So we're kind of like reversing that growth process. We're, shrinking it and we're softening it. So embolization is a medical term, meaning that we are injecting something into a blood vessel. And, I'm sure people have heard of kind of like the pulmonary embolism where you got a blood clot that travels, right? Well, what we're doing is we're injecting something and then that travels through the circulation and then deposits in a certain area. So that's what embolization is. So that's what the procedure is.
Yeah, but much safer than like an embolism. I mean, the particles and the
Right, right. I mean,
vessels you guys
we're
are.
doing something, we're injecting a particle or sphere into the organ and we're doing it safely. We're doing it to starve the gland.
I love your visual. So the visual I always show, right, is I take a pen like this, and this is your prostate gland, and the blue is your urethra. So the bladder
Mhm.
would be on top. And if it's
Sure.
swollen, it squeezes on here. And as you do the embolization and you starve the blood, like you're talking about, it shrinks. And guess what? Now you
Yeah.
can pee, right?
Yeah.
So
Yeah.
I
I
think
like
it's
that.
hard for a lot of people who don't really understand the anatomy, and they're like, what does my prostate have to do with my bladder? They think other
Sure.
things.
Yeah.
Your visuals of like constricting and what it
The
does
fist. Yeah.
is perfect. Why do you think most men don't know about PAE versus the traditional treatments that their urologists tell them about?
It's kind of like the typical referral pathway. So, the typical referral pathway is a gentleman complains of these lower urinary tract symptoms, tells a physician, typically it's the primary care physician. And the primary care physician will be like, okay, well, I could start you on some medications and I'll just refer you to urology because that's like the typical pathway. And then the patient gets kind of dialed into that, care path. And that's kind of the traditional things. The whole goal is to, increase patient awareness so that they know there's other treatment options out there. When you're talking about treatment options for BPH, for benign prostatic hyperplasia, if you go along, the spectrum, you go along the spectrum of least involved or least aggressive to like the most involved and the most aggressive, right? So, the first thing is lifestyle changes. Like, what can a man do, manage his lifestyle to improve his symptoms? And, those things would be kind of like, fluid restriction in the evening so that they don't have to wake up in the night and pee, avoiding certain types of drinks like, coffee with caffeine or avoiding alcohol, things like that. These are like kind of like lifestyle things that they can do, right? In a sense, they're kind of like, they're managing their fluid. They're not really managing the prostate. As you go down that spectrum, you start thinking about medications. There's some called Flomax. What that does is it relaxes the bladder sphincter. So it's kind of like one less thing for the bladder to have to push against is to relax that sphincter, but the constriction of the urethra is still there by the prostate.
Mm-hmm.
But it does help. There's also a medication, it's called finasteride. And what that does, is it medically can shrink the gland by kind of blocking hormone. That has side effects
Yeah.
and some good, some bad. Really, how much does it shrink the prostate anyway? And then, so traditionally, you have what men can do from a, lifestyle point of view, and then the medications. And then you used to have like this huge jump to surgery. Typically, you kind of manage your symptoms based on like how bad they are, like how severe they are. So when you're kind of like on the mild range, everyone's kind of cool with the lifestyle and the medications. And then if you're super miserable, then you start going to surgery. And at that point, you're willing to undergo the side effects and the risks and the complications of surgery. But there's like this big hole in this area where, you got men who they're not super miserable, but their lives are negative and impacted, and it does make them miserable. They're just not super miserable that they're willing to go all the way to that extreme end. So the PAE procedure, it fits really well in this entire spectrum, all the way from like, mild symptoms all the way to kind of, severe. And because the PAE procedure kind of treats the full spectrum of it. And so the procedure itself is minimally traumatic. The recovery is very tolerable. Side effects are minimal and the complications are very low. So gentlemen aren't at this total miserable end where, they have no other option. They can do this procedure throughout that entire spectrum. And, you'll have a guy who'll be like, yeah, I just don't feel like taking my Flomax anymore. I'm a cyclist and I'm not at my peak performance. So yeah, I'm going to do this procedure. Or some guys are just like, I just don't like taking medications. So they're going to do the procedure. It really fills this entire spectrum really well as a treatment option.
I like that you mentioned it could be, I mean, first, probably medication is always the best place to start, right? For most
I
people.
think medications is a good start. And I think that, medications, what they do is they can be both like kind of diagnostic and therapeutic. And
Hmm.
what I mean by that is the symptoms of the lower urinary tract symptoms of, BPH are non-specific. It could be like bladder overactivity. It could be like anxiety, whatever. It might not even be BPH, right? You could start these medications and they could help. And you're like, okay, well, this kind of proves that it's BPH, right? And then treat the BPH and the mild symptoms of it. So I think as far as like when a guy should kind of start thinking about stuff, if you're having symptoms, just talk to your primary care doc. Jump online and educate yourself too. But the first thing to do is really, have like somebody, kind of help you navigate, where to go in the system and what to do, right? And it's not up to the man to figure out. It's not up for any patient to kind of, guide their own healthcare, right? That's what we're here for.
You mean don't use Dr. Google? They're not going to tell me what's wrong.
Yeah, I mean, Dr. Google is great. I use him or her all the time.
Well, now you got ChatGPT and Claude and all
Yeah.
those other AI
Yeah.
tools out there.
Well, I think what it is, that really opens the door of like, insights into kind of what it is. But you still need somebody to kind of, guide you through and all that.
No, I mean, we're in the digital marketing space, right? People are using Facebook and Instagram to look for alternatives. So this is
Sure. Yeah.
exactly what's triggering this conversation. I
Yeah.
want to go back to the procedure itself, though. For you mentioned minimally invasive, like it's not traumatic, you can recover quickly. Do men like instantaneously have results? Does it take time? Do they have to do this more than once? And like, what is
Sure.
when you say recovery, like, do they have a catheter? Are they out of work for a few weeks? What's that like?
I guess the best way to kind of, describe like, what it is to describe the actual procedure itself, like what happens on the day of the procedure and all that. So the day of the procedure is, a gentleman will come in and, they're typically at our location for a few hours. We have an anesthesia team. What the anesthesia team does is they sedate. So sedation is kind of like a medicated sleep. If you guys like, spectrum of being somebody wide awake, and then you got the spectrum all the way of like somebody being anesthetized where, they're completely paralyzed. They have to have a machine breathe for them, right? All that stuff. Okay. So what sedation is, this is like being wide awake, then this is being like normal sleep. Okay, well, sedation is like right here. It's like, just a little bit deeper than normal sleep. We can rouse you, we could wake you up. You're breathing for yourself, you're maintaining all your protective reflexes. And then all we have to do to wake you up all the way is turn off the medication and
Hmm.
you're awake like within minutes.
Yeah.
Okay. And then when I talk about like how the procedure is minimally traumatic, right? So the procedure itself is not very traumatic at all. Okay. And the reason why we do the sedation is because so that a man can like lay still for about 45 minutes or an hour. And that's the time it takes to do the procedure. And that's what the sedation is all about. It's not that anything crazy is going on. It's not that anything super painful or anything, crazy is going on, right? Basically, what we do is, with the man sedated, is we kind of numb up the skin in kind of the forearm area or like the right hip area, kind of where the crease of that thigh and the hip are. We just numb that area up. If somebody's awake for that, they basically feel like kind of like a pinch and burn. Other than that, just pressure as the tiny fiber goes into circulation. Well, other than that, they don't feel the fiber going through their circulation. And then if they're awake, which they're not, but if they're awake, they would feel kind of warmth in their pelvis as we take pictures. But other than that, they don't feel anything. They don't feel the fiber going through their circulation. They don't feel the microspheres going in and wake up with a Band-Aid on that access site. Physical recovery from the procedure is about minutes to hours. That's how long it takes you to kind of physically recover.
Okay.
Basically, with a Band-Aid on your forearm or your hip area, we watch you for about an hour and then you kind of go home. The procedure itself is typically not associated with a urinary catheter in the recovery phase.
Wow.
Not 100% guaranteed, but
Right.
not typically
Yeah.
associated.
I mean, when you're talking about a TURP or a major surgery, that's 100% guaranteed you're going home.
Yep, correct. You're so insightful, Rachel. Yeah, I mean, you're 100% going to get a urinary catheter. And there's going to be a likelihood that that urinary catheter is going to be connected to a bag that's strapped to your thigh that has bloody urine in it.
Yeah.
And that could
That
be in
sounds
for
scary.
days.
I mean, and I don't
Yeah.
have Yeah.
Yeah. Yeah. Yeah. You're like,
Yeah.
that's not something I got to deal with. But yeah.
No, no, but still, if
Yeah.
I were a man and had to choose
Yeah.
between one option, option A or option B, I'm looking at
Yeah.
PAE for sure.
Sure. So we're kind of going down this progression. So yeah, the recovery is very tolerable. The man can have exacerbation of their symptoms, which is like kind of worsening of their symptoms because the gland can swell, relate to the procedure, but that's why we have like some recovery medications. And
Mhm.
then that kind of, mitigates that swelling. And most guys do pretty well. They might have some worsening of their symptoms for about 2 days, after the procedure, but then after a few days, it's back to, kind of their baseline. And then this is going to address, one of your questions where if you think about it, right, like it's not overnight that the prostate's going to go from its big constriction, just be like small. And typically I would say it's about 2 to 3 months to start getting, the significant, feeling of reduction of symptoms. And that's because the gland doesn't, shrink and soften up overnight. It takes a couple months.
So symptoms will improve week over week after PAE.
Sure.
Do
Yep.
they ever have to do it again? Like I know, I mean, there's two parts to the prostate. Are you taking care of both sides, left and right?
There's a lot of considerations when you think about prostate. Now, so this procedure is very technically challenging procedure. It's not like we're finding the urethra and then, kind of putting a roto-rooter through it, right? What we have to do is we've got to, we're getting access into this blood vessel here, and we're guiding this tiny fiber going down the circulation and finding these 1 to 2 millimeter blood vessels in the tangle of hundreds of blood vessels that are in the pelvis. These are very tiny blood vessels, and we have to, identify them in the hundreds of blood vessels in the pelvis. We try to do it all in one shot, obviously in one go, but depending on, the quality of their blood vessels and their size and their, anatomic variances and all the other stuff, that we can't guarantee that it gets done in one procedure, but we guarantee that we can do it.
So you could do it more than once, because we get asked that a lot, right?
Sure.
Like, what if it didn't work the first time? And we get that asked that for genicular artery embolization, shoulders, all kinds of stuff. And I feel
Yeah,
like most IRs would rather be conservative, right? And do a little
sure.
bit, see what relief you get. And then if it's still not, like you said, adequate enough for life, it's still kind of like just disturbing their everyday life, you could do it again.
It's like I said, the recovery and the the minimally invasive part, the non-traumatic part, these are all very tolerable. It's not like, getting connected up to a urinary catheter again, having a bloody bag of urine again,
Mhm.
having extreme pain or whatever. I described the procedure. You come in, you're sedated, wake up with a little Band-Aid on your access site.
That's awesome. I think also the side effects or lack of, right, for
Yeah,
a PAE procedure versus, I mean, the big one, let's just talk about the elephant in the room, is sexual
yeah,
dysfunction. You know,
yeah,
that's a
yeah,
huge concern for most men having any sort of, even the side effects with like retrograde ejaculation from medications to
yeah.
sexual dysfunction with having the actual surgery done. That's a big concern for a lot of men. So, what's the percentage of that being an issue for PAE?
If we're going to talk about kind of like the traditional side effects, and we're talking about, negative side effects, right?
Yeah.
So what are potential side effects of surgery, right? You could have leakage of urine, which is incontinence. You could have retrograde ejaculation where, instead of ejaculation coming out, it goes inside and goes into the bladder. And then there's a lot of nerves associated with the prostate. So there can be some, like neurological, dysfunction after. So these are all potential side effects, right? And these are potential side effects of surgery. They're like small percentages, right? However, like when it happens to somebody, it's like 100% to them.
Yeah.
Whenever somebody is like, oh yeah, well, complication rate is like, 1 to 5%. And people are like, oh well, that's great, right? 1 to 5%. But if it happens to them, it's 100% for them.
Because
And
they're
so
kind of big deals, right? For a man. I mean,
yeah, I mean, yeah,
they
so
might sound small clinically, but for your everyday who you are,
yeah,
it's a
yeah.
lot.
I think I kind of got off track, but basically what I'm saying is like, these side effects, they're rare, but when they happen, it's life changing, right? And so the PAE procedure is not associated with any of these side effects. Okay. It's not associated with incontinence. It's not associated with retrograde ejaculation. It's not associated with neurological dysfunction. We're in the blood vessels, and it's impossible to mess up any of those other, any of those other areas. There are none of these like side effects and complications following the PAE procedure.
I think that's really important for people to hear, because that to me on our end, when we get on the phone with a man or even their partners, right? Their wives are calling most of the time to
Sure.
say, hey, I saw your ad on Facebook. My husband keeps me up at night. He's too embarrassed to talk about it, whatever it might be. And they're scared of the side effects and what possibly could happen. I think honing in on minimally invasive, back to work right away, no
Yeah.
catheter, no cutting, like you said,
Yeah.
and almost zero side effects that traditional surgeries would carry.
I think so. We're talking about, elective procedures for patients. The big prostate, that's not life-threatening. What we're doing is we're going for symptomatic reduction. We're treating somebody's symptoms, right? Goal is to improve their life, not keep their life as it is or make their life less good. I've got gentlemen who've had surgeries before, and they're kind of like, oh, well, I'm scarred now. I can't. I have retrograde ejaculation. My relationship with my wife is, different now. I'm embarrassed, all these things. And, these things are kind of irreversible. I think the PAE procedure, the fact that, that it's not associated with any of these negative side effects is makes it a great treatment option. I kind of want to put things back, and so we got this treatment spectrum of lifestyle changes, of medications, of procedures, of surgery, and there are surgical procedures that are less traumatic than the TURP, but they're still transurethral. And they're still associated with needing the urinary catheter, and there's the recovery issues. But when we're talking about the spectrum of treatment, okay, and the fact that the PAE kind of can sit in this entire length of treatment spectrum, the fact that, what I kind of described, like, how the recovery is, we talked about the side effects, we've talked about the benefits, the risk mitigation too. There's no anesthetic risk, there's no surgical risk with this procedure. So just to kind of talk about that, but basically, like when you talk about the recovery and you talk about, the risks and the benefits of the PAE procedure, it really like kind of lowers the threshold for a man to seek treatment, because like you said, they don't have to worry about all those things that people worry about, like the side effects and, the recovery and all that. And the other thing that's great about the PAE procedure, okay, is that it has the ability to kind of like downstage. If you got a guy with like a super huge prostate, okay, and TURP is his only option, us doing the PAE procedure is going to shrink the gland and make it softer, that maybe he won't need the TURP. Maybe he can undergo another urological procedure that's less risky and better fits his, fits his profile, right?
So you're saying still working in conjunction with the urologist plan, it just helps
For
recovery and the
sure.
process itself.
For sure. And I think like from a multi-modality point of view, right? So like the PAE procedure has like forward compatibility and backward compatibility. And so that kind of means that, a man can have a urological procedure and still have residual symptoms, and the PAE could come in and give synergistic effects, right? Same thing. You could do the PAE procedure, and if it's not enough, you could have the synergistic effects of another, procedure after. So what the PAE procedure does is it actually optimizes the gland if the patient needs something else in the future.
Yeah.
Right. So it's going to make the gland softer. It's going to make the gland smaller, and it's also going to make the gland doesn't bleed. Right. So if the man has to go another procedure in the future, then, his recovery and his complication risk and all that are going to be lower because everything's going to be easier.
Yeah, that makes total sense. I have a family member who just had his prostate removed and his recovery was terrible. I mean, he had cancer, unfortunately, so there wasn't
Yeah.
much option. It was like 90% of it, so the whole thing had to come out. But just the visual of the catheter with the bloody bag, I mean, that was enough to to make him
Yeah.
almost pass out every day just seeing that, and thinking
Yeah.
about where it came from. But
Yeah.
if he could have had possibly a procedure like this prior, shrinking it, softening, maybe he wouldn't have had so much bleeding post. Like I'm just thinking of him in
Yes.
particular, but that's really interesting to know. Do you partner with some of your local urologists for these type of treatments too?
Yeah, we do. I'm a fan of kind of like a multidisciplinary approach. The goal is for comprehensive treatment options. Comprehensive meaning, they have access to and have the ability to choose, I guess the ability to have them all, at whatever stage they need it. It's, kind of treating the symptoms of it and treating the actually enlarged gland. I mean, it's good to have the primary care doc involved, because primary care docs are always kind of like the advocate for the patients. They get them in the system and get them to the right people, and then kind of like synergistic relationships with us and urology. I mean, the patient's going to have it all.
I think that's what's great about embolization procedures in general, is you're right. You can still have collaboration between other specialists where anything you do with an embolization isn't gonna disrupt what maybe the urologist wants to do or the
For
orthopedic
sure.
physician or someone else down that patient's line of care.
For sure. Yeah.
You're just kind of in the middle, like, let me help you right now. Let's get your pain under
Yeah.
control. Let's take it away. Let's make it better. Let's shrink that prostate. So when you get to this step, I think that's what I love about embolizations in general,
Right.
like talking about all of
Right.
them, right? You've probably
Yeah.
seen it when you've done all your genicular arteries or
Yeah.
shoulders or whatever else
Yeah.
too.
You're super insightful. Like I use a term like forward compatibility and backward compatibility of what we do, right? So what we do doesn't, contraindicate what somebody else needs to do in the future. And then what somebody else does, before us doesn't contraindicate what we do. So,
You're like the safest bet. You're like base.
I love that. But
Really, literally, like, why? I mean, I don't have a prostate, but I would work with any your IR.
yeah,
Seriously.
you're like, sign me up. I don't have a
Sign me
prostate,
up,
but I'm
Dr.
down.
Lee.
I think these procedures do a really good job. Question that I get a lot is, how come, nobody knows about this, or how come I didn't know about it? And, why isn't everybody getting this done? What it comes down to is awareness
Yeah,
and
100%.
knowing you've got that choice and going down that pathway. And if you look at the PAE procedure, in certain respects, it's kind of like a magic bullet, but, we're dealing with a challenging circulation, we're dealing with a challenging procedure, and it could take 2 to 3 months to like kind of kick in. It can be a magic bullet. But I think that the way that the industry is going as far as like treating BPH is that in the near future that the PAE will probably be like kind of like first line treatment for the enlarged prostate because of its risk profile, because of its, recovery and, the mitigation of side effects and complications. And the fact that, it's very well tolerated and it has forward compatibility, backward compatibility, that it will likely become the first line treatment for BPH.
So I really like that. And I'm wondering, like, is that going to come from the primary care doctor? Do you really feel like urologists are going to be like, yeah, go see my friend Dr. Lee first before here? I don't know, right? I think the question would be for a patient, for if there's a man out there right now who maybe has been struggling with frequent urination at night, getting up multiple times to go to the bathroom, struggling to even empty their bladder, chronic urinary tract infections, those sort of things. Where should they start? Like, what's the first step?
But what I'm going to do is I'm going to address like your first question. I think it's kind of related to the fact that will urologists be okay with us doing this procedure? And I think that like a progressive thinking urologist is not going to be threatened by this procedure. The main reason is because I would say about 80% of the patients that I see for the BPH, for the PAE procedure, they would never undergo surgery anyway, no matter how bad their symptoms are. So therefore, like us doing the PAE procedure, we're not cannibalizing, our urology colleagues because these guys would never, ever get surgery anyway. And I think that like when the PAE procedure, I've been doing the PAE procedure since like 2016. When we first started doing it, they were threatened by it and I could understand why they would be, right? But, as kind of like the relationship between us and them and our patients evolve, we're not taking patients away from them. We're just offering their patients treatment option, make the patient accept if they do need a urological procedure, that they're not getting TURP, that they're getting something else that the urologist that is within the patient's profile and willing to do. So
I think another thing to address with your specialist referrals and patients is maybe those patients that have other comorbidities and can't have a major surgery, right? For whatever medical reason, they can't undergo a major surgery like that. That's a great candidate for a urologist to say, you really need a TURP. And they could be like, okay, but physically you've got these other ailments. Let's start with PAE first.
PAE is, like I said, very tolerable. And we're dealing with like, older male population. And some of them have, some comorbidities that, kind of prevent us from, being very, heavy with sedation. There have been many a time that I've done a procedure on a man, then they're completely wide awake, just some local anesthetic at the access site. The only uncomfortableness is like, we got to make conversation while we're doing the procedure.
How's it
That's
looking down there, Doc?
yeah, yeah. I'm just like, yeah, I mean, that's the uncomfortable part of the procedure is that, we got to make
Yeah,
conversation.
but how amazing you can do this while they're awake. I've been in the
Yeah,
OR before and I've had full-on conversations with patients while the doctor's got the C-arm over them. They've got down there where their catheters, and
yeah, yeah,
they're like, how's it going? Like, we're almost done. You good? Can you feel anything? Not a thing. We play
yeah,
music. Like
yeah,
that's cool. I think that's what people need to know. This is not scary. It's
yeah,
outpatient. You're in a twilight sedation. You're kind of awake. You're not going to feel anything. There's no pain. Like it's like
yeah,
I was at the dentist this morning, and they want to give me the laughing gas and numb me up. I'm like, sure, whatever, why not? Just
yeah,
for
yeah,
me, it's more of anxiety of like the sounds
yeah,
of what's around
yeah,
me.
yeah. True, very
And I
true.
think that's probably what all your sedation helps with is the anxiety and the worry
It's
of
yeah.
that.
I mean, the thing is, sometimes I used to describe the procedure as being no more uncomfortable than a routine dental procedure
Yeah,
until I had a guy who needs anesthesia for a dental procedure.
right.
Because there are people who need, anesthesia because they're so like nervous. So the sedation is not for, like you said, not because anything scary is going on, is to kind of take the edge off and help you lay still
Like
for
a
about
good
45
cocktail
minutes.
right before you're going to go to bed.
Right, right.
So there was two parts to my question.
Oh yeah, yeah. What was the second part? I forgot.
The last one was where should someone start? Like a gentleman is having these symptoms. Does he start with his PCP? Like, well, what's your words of advice for him to stop delaying treatment or options?
I think contacting prostate specialist at any time for lower urinary tract symptoms is where to start. And at least they get dialed into the system. It's not often that I see a man who's coming in and he's not really coming in for BPH. He's coming in because his dad or his brother died of prostate cancer. And he's like scared and he's just like, I need to see somebody. So, so being a prostate specialist, he'll come to us. We don't treat cancer per se of the prostate, but they come to us and we're like, and that's where I'm like, hey, I'm glad you came. I'm here to, allay your worries. Let me refer you to, a urologist or a PCP. We'll draw your PSA, check that, see where you are, blah, blah, blah. And then if you need anything, we'll work you up further or whatever. So whatever it is, whoever you are out there, whatever symptoms you're having, just go see somebody and then, we'll be able to steer you in the right direction. You're not wasting anybody's time. So as far as like, having lower urinary tract symptoms, okay, so if you're having, peeing at night, straining, there's kind of like two categories of them. Okay. There's more of like an obstructive component. Okay. And there's more of like an irritated bladder component. And so the obstructive, category is like kind of straining when you pee. You kind of force yourself to pee and then it dribbles out and then you got to push and start again. That's called intermediacy. I can't remember the term, but I'll have to look it up. But anyway, so there's like those obstructive symptoms. Then there's like kind of the overactive bladder symptoms. That would be waking up multiple times at night and then peeing a little bit amount, pain when you pee, so those are kind of like, obstructive versus urinary, like kind of irritated bladder symptoms. And BPH can be causing any of those
Yeah.
combination, whatever. If you're having symptoms, just see a prostate specialist and then, or talk to your PCP about it and they'll be able to refer you and send you out. But certainly come to us and we can get you worked up from, from more of like a kind of specialist point of view too.
And ask for prostate artery embolization, right?
I think that all treatment options have their space and their scope and their role. Fortunately for us in the PAE specialist world, we treat that entire spectrum. Yes, certainly come to us. We can guide you.
Dr. Lee, this has been really informative and fun. Appreciate you being on with me today. We can find you in georgiaeva.com, right? Your website. And you guys have
Right.
multiple locations in that area out near Atlanta.
Yeah, we've got 3 locations in the greater Atlanta area. And, we want to make ourselves accessible. My philosophy, being in the outpatient world, is that we're making ourselves available to the community. What I'm passionate about is providing, this level of service and the availability of these technologies and, this highest level of care using the highest level technologies. I would say, the best physicians, are here in the community and available to patients and it's convenient.
Yeah,
And
it's all
accessible.
about awareness and access, right?
Yeah.
Making patients aware of what options are out there and then how to access that. And that's what I love about working with interventional radiologists in an OBL setting, which is an office-based lab,
Yeah.
outpatient, for those that don't know what that means. You don't have to go to the hospital. You don't fight all the red tape and like the wait time to get an OR table, the insurance crap. There's all these
Yeah.
different fees. People get home and they
Yeah.
think, oh, my insurance will cover it. Next thing you know, a month later, you've got thousands of hospital bills because there's so many different bills coming from different people.
Yeah. Yeah.
Never mind all the sick people in the hospital and things you can avoid. So I love that you mentioned that, like outpatient access. This is great. There needs to be more. I think all of us encouraging like associations like OEIS and the ones that support you guys, we need more OBLs. We need more access for
Yeah.
patients to be able to see doctors like you and get treatments like PAE. So thank you for what you do. And
Thank
thank
you.
you for being with me on this. This was awesome.
I guess I want to say one more thing. I've been doing this a long time. I may not look like it. Actually, maybe I do look like it. I got a lot of gray hair. But anyway, when I first finished training, what it was about, taking care of that one single patient that you're dealing with right then and there. Not saying that that's gone, but like your primary and only focus is the patient in front of you. And then as you get more seasoned and you get more experience, you're like, okay, well, I'm not just taking care of one patient, I'm taking care of a population of patients, right? So, set of patients, whether they're cancer patients, whether they're, urology patients, whatever. You're taking care of like a certain segment of patients. And then you start saying, okay, well, I'm going to focus on the community around me, right? Like what benefit, what impact can I give to the community around me? And that's kind of what we're doing in the OBL space. We have a focus on the community around us, right? And taking care of patients that way. And I think that when you look at like kind of the model of the outpatient space, right? Like it's almost like, we're impacting patient care on a national level. We're more efficient, we're just as effective, or maybe more effective because of our accessibility. We're providing like the best technologies and the best techniques. You're not missing anything getting your care in the outpatient world. So basically, what we do in the OBL space is we drive down the healthcare costs. We do things more efficiently and just as effectively. And really what it is, like if it cuts the cost tremendously. I think that like our reimbursement rates are probably like half of what it is at a hospital. So if a procedure is done at a hospital, it's double the cost of what we do in the outpatient world. That's significant. So really what we do is, we're impacting patients, we're impacting that single patient, we're impacting that population, we're impacting the community around us, and we're impacting the nation in what we do. And so I
Yeah,
appreciate you for helping us get our word out there.
of course. Yeah. Let's just keep pushing each other and encouraging each other and bring awareness to all of it, right?
Yeah. Thank you so much. Yeah.
All right, awesome. Thank you, Dr. Lee, so much for being here with us.